All right, we're putting you in the hot seat today. We're going to run through a simulated high-stakes surgical oral exam, a viva, where your clinical judgment gets tested in real time. You see, this isn't just about reciting facts from a textbook. It's about thinking on your feet when the pressure is really on. Let's see how you'd handle this one.
Good morning. Please have a seat. This is a 10-minute station. I'm going to present a clinical scenario, and I expect you to manage it as if you were the responsible surgeon. Ready to begin?
So here's the roadmap. We'll kick off with a clinical scenario, and then it's on you to lay out your initial plan. From there, we'll dive into the evidence, I'll throw you a bit of a curveball, and then you'll need to put together a definitive surgical strategy. We'll wrap it all up with the kind of critical takeaways you just can't afford to miss in an exam like this.
All right, let's get started with a case. Pay close attention to the details.
This patient is on your service. Tell me how you would assess and immediately manage her.
Okay, thank you. So we've got fever, pain, and bilious fluid from the drain, all happening 5 days after surgery. I mean, this is the classic picture of a post-operative bile leak. And that fever, that's telling me sepsis is brewing. My approach has to be systematic and it has to be fast.
My first thought is stabilizing the patient while we figure out the source of the problem. For me, that boils down to 4 immediate critical actions. Okay, so here are my priorities. In order. Number 1, source control. We have to stop that bile leak. Number 2, drain the collection. There's almost certainly a biloma in her abdomen that's fueling this infection. Number 3, get control of the sepsis. That means fluids, getting blood cultures, and monitoring her vitals like a hawk. And that leads to number 4, start broad-spectrum IV antibiotics immediately. We can always tailor them later once we know what we're fighting.
While all that is happening, I need to get a better look at the anatomy. I'd order an MRCP. It's non-invasive and it'll give us a great roadmap of the biliary tree. But here's the real pitfall, the thing you absolutely can't miss. These types of injuries have a really high rate. We're talking 10 to 30% of a concurrent right hepatic artery injury. Missing that would be a complete catastrophe. So I'm also getting a CT or MR angiogram to rule that out. If that artery is damaged, our whole game plan changes.
Very good. Your investigations are done. The CTA is normal, no vascular injury. The MRCP, however, gives you a definitive finding.
This is the key image from the MRCP. Describe what you're seeing, and please classify this injury for me.
Right. So what we're seeing here is a leak, but it's not coming from the main duct or the cystic duct stump. It looks like it's from a separate aberrant duct, most likely a right posterior sectoral duct. Now, using the Strasbourg-Bismuth classification system, this fits perfectly as a type B injury. And knowing that classification is everything, because it tells us exactly how to manage it.
The great thing about a type B injury like this is that you can often get away with non-operative management, just drainage. Now, if that part of the liver keeps getting infected, a formal resection might be on the table later. But this is a world away from, say, a type A leak from the cystic duct, which you just pop a stent in with an ERCP. And it's completely different from a type E, a major stricture, which is a huge deal and almost always needs a big reconstruction like a Ruin J hepaticojejunostomy to create a new drainage path for the bile.
Excellent. Let's say you've managed the leak conservatively with a drain and your patient is stable. But a week later, you get a call from pathology about the gallbladder specimen from her original operation.
This changes everything. This is no longer just about managing a surgical complication. You now have an unexpected finding of cancer. Tell me your definitive plan.
Wow, okay, that's a game changer. A T1B gallbladder cancer. That means the tumor is into the muscle layer. A simple cholecystectomy is absolutely not enough. We need a whole new strategy. This means a full staging workup, then a much bigger reoperation, and then planning for adjuvant therapy.
Okay, first things first, we don't touch her until she's fully staged. I'm ordering a high-quality CT or MRI of the liver, plus a full CT of the chest, abdomen, and pelvis to hunt for any spread. I'll also check baseline tumor markers like CEA and CA1999. And here's a point that is absolutely critical. We do not go in and biopsy the gallbladder bed before the main surgery. The risk of spreading cancer cells is just way too high.
So once the staging shows us it's resectable with no distant disease, the standard of care is to go back to the operating room. That surgery has 2 non-negotiable parts. First, a radical cholecystectomy. That's not just taking the gallbladder out. It's resecting a chunk of the liver it was attached to, segments IVB and V, to make sure we get clean margins. Second, we do a full portal lymph node dissection to properly stage the cancer and clear out any local spread.
And here's a number that's money in the bank for this exam. You must retrieve a minimum of 6 lymph nodes for it to be considered an adequate cancer operation. If you get any less than that, you haven't properly staged the patient, and that directly affects whether or not they'll get further treatment.
And the plan doesn't stop when she leaves the OR. Based on that final pathology, any tumor that's T1B or worse gets considered for adjuvant therapy, usually chemotherapy, to clean up any microscopic cells left behind. After that, she enters a very strict surveillance protocol. We're talking imaging and tumor markers every few months for the first 2 years, then spreading it out annually for up to 5 years.
Good, that's a very comprehensive plan. Let's finish with a few rapid-fire questions. I want to test your knowledge on safety and when to hold back. This is a question of pure surgical judgment. When do you have to look a patient in the eye and tell them that a curative surgery just isn't an option?
There are several hard stops. Number 1, the patient simply isn't medically fit enough to survive a major liver resection. 2, they have distant metastatic disease. 3, the cancer has spread to N2 lymph nodes around the pancreas, which is considered metastatic. 4, malignant fluid in the abdomen or ascites. And 5, the tumor is encasing major blood vessels like the portal vein, which means you just can't get it all out safely.
And that's time. This case is just a perfect example of why surgery is so incredibly challenging. It started off as a manageable complication, but then it completely morphed into a complex cancer case. It really shows you can't just be a technician with good hands. You have to be a strategist, someone who's ready to pivot the entire plan at a moment's notice. And it leaves us with the real question. In a situation like this, would you be ready to manage not just the problem you see, but the one you never saw coming?